So, when you take a flash photo and sometimes you get those bright red eyes? Well, what if instead of that normal red, you saw a weird yellow glow? Might sound like just a photo glitch, right? Something you'd maybe just ignore or delete. But for quite a few families, that exact glow has been the very first sign, the critical clue to a really life threatening condition in their child. Today, we're doing a deep dive into retinoblastoma. It's a rare eye cancer, but incredibly serious, and it mainly affects very young children.
Yeah, and our mission for you in this deep dive is really to shed light on what retinoblastoma actually is, how doctors spot it, the sort of complex genetics behind it all, and crucially, the amazing progress in treatments that have just completely changed the outcome for these kids. We'll also touch on the vital long-term care and support that families need. It's quite a story, actually. Going from something that was almost always fatal to now having survival rates over 95% in developed countries, it really shows the power of catching it early and medical breakthroughs.
Right. We've gathered insights from a whole range of sources, top medical experts, research institutions doing groundbreaking work, and also those vital patient support groups. Our goal is to give you a really solid but, easy to grasp picture of this challenging cancer. And look, even if retinoblastoma hasn't touched your life directly, understanding this whole journey, the detection, the genes, the way treatments have evolved, it gives you incredible insights into where pediatric oncology is heading. Personalized medicine, too. So what does all this really mean for families going through this, and maybe what does it hint at for the future of cancer care in general?
Okay, right. Let's unpack this a bit. We mentioned that glow, but what is retinoblastoma fundamentally? Like, what's happening inside the eye?
Well, at its core, retinoblastoma is a cancer, a tumor that grows in the retina. That's the light-sensitive lining right at the back of your eye. It's actually the most common cancer that starts inside the eye in children, and it's usually found before they even turn two. Often it's just in one eye. But yeah, sometimes it can develop in both. And the retina, just to be clear, that's absolutely vital for seeing, isn't it? It's kind of like the sensor in a digital camera.
Exactly. That's a great analogy. The retina is this complex layer of nerve tissue. Its job is to sense light, turn it into electrical signals, and then shoot those signals off to the brain. The brain then interprets them as the images we see. Now, retinoblastoma, what happens is specific DNA changes, mutations, happen in those retinal cells. And these changes make the cells grow completely out of control. They just multiply and multiply, forming a mass in the tumor.
Okay, and this is where we get back to that really striking sign, the one that's so often key for catching it early. The leukocoria, that white pupil reflex. That's the yellowish or whitish glow you might spot in a child's pupil, right? Especially in flash photos where you'd normally see red eye. People often describe it as looking like a cat's eye.
And that's not just, an interesting detail. It's often the most critical first sign. Leukocoria is the most common way it presents itself. It shows up in, well, over half of all diagnosed cases, 56%, according to one source. Catching it early is just absolutely crucial. Because if retinoblastoma isn't treated, it is fatal. But finding it early, that saves lives. It can save the eye itself and give the child the best possible chance at good vision. Those photos, they've genuinely saved children's lives.
Wow. Okay, so beyond that glow, which is obviously key, are there other signs parents or maybe doctors might look for?
Yeah, while the glow is definitely the most common thing people notice first, there are other possibilities. Things like strabismus. That's where the eyes don't seem to line up. They might look in different directions. Sometimes people call it crossed eyes. You might also see redness or swelling in the eye that just doesn't go away. Or maybe it's obvious the child isn't seeing well out of one eye. But really, that white or yellow reflex in a photo, that's the alarm bell you hear most often.
So really important takeaway here. If you or anyone you know spots that unusual white or yellow reflection in a kid's eye, especially if you see it in pictures, don't just brush it off. Get it checked out by a doctor right away to rule out retinoblastoma. Waiting is not the way to go. Okay, so that glow is the critical warning sign we can see. But let's dig a bit deeper. What's actually causing this cancer at the genetic level? What makes these cells go rogue?
Right. The fundamental cause lies within our DNA, specifically with a gene called RB1. It's located on chromosome 13. Now, the RB1 gene is what we call a tumor suppressor gene. Its normal job is basically to act like brakes on cell growth, controlling when cells should divide and when they should stop.
Okay, so it's supposed to prevent tumors, and when it's not working right, the brakes fail. There's this concept called the two-hit hypothesis that's really central here, isn't there? Can you explain that?
Yes, it's a really key idea for understanding retinoblastoma. The two-hit hypothesis basically says that for this cancer to develop, both copies of the RB1 gene in a single retinal cell need to be damaged or mutated. You need two hits. Now, in about 60% of cases, these mutations are sporadic. They're non-hereditary. Both hits happen randomly, just
Mm.
by chance, in one cell in the retina. That usually leads to cancer in just one eye. But in a pretty significant number of cases, around 40%, some studies suggest the condition is hereditary.
Hereditary. Okay.
In the hereditary form, the child actually inherits the first mutation. It's present in every single cell of their body right from birth. Then, they only need one more hit, one spontaneous mutation in any retinal cell for the cancer to start. And because every retinal cell already has that first hit, they're at much higher risk.
That makes a huge difference. So what does having that hereditary form actually mean for the child and for their family? What are the sort of practical consequences of inheriting that first hit?
Well, it fundamentally changes their risk profile and their long-term health outlook. If a child has the hereditary form, their risk is significantly higher. These cases are much more likely to affect both eyes, often with multiple tumors popping up in each eye, and they tend to develop earlier, typically before the child even turns 1. But here's a really crucial point. Children with hereditary retinoblastoma also face a much higher lifetime risk of developing other kinds of cancers later in life, completely separate from the eye. We're talking about things like bone cancers, bladder cancer, breast cancer, certain lymphomas, lung cancer, melanoma, a type of brain tumor called a pineoblastoma, and soft tissue sarcomas too. So their follow-up care needs to be different, much more comprehensive and lifelong.
Gosh, that sounds like families are suddenly faced with a massive amount of complex information and probably some really difficult decisions. This is where genetic counseling must be absolutely vital.
Absolutely essential. Genetic counseling becomes an incredibly important part of managing this whole situation for these families. A genetic counselor can really help them understand their specific risks. They can arrange genetic testing not just for the child, but often for parents and maybe other relatives too. And importantly, they can explain what those complex genetic test results actually mean in plain language. They also talk through ways to manage those future cancer risks we mentioned. It's also a really tough conversation, you know. It can bring up difficult family history or create new anxieties. That's why counselors often suggest maybe bringing a supportive friend along or even recording the session, just so you can absorb all that complex, emotionally charged information. It's a lot to process in one go.
That makes sense. And is there anything practical families can do if they maybe have a vague suspicion, like an old family story?
Yes, definitely. You're actually encouraged to ask older relatives if anyone in the family had an eye removed as a child. Even if the reason wasn't clear back then, it could be a really important clue. The genetic counselor will often map this out visually, drawing a family tree, they call it a pedigree, to trace the risk patterns through the generations.
It's really striking when you look at the history of treating retinoblastoma. It's been just a dramatic transformation, hasn't it? You mentioned maybe a century ago, it was almost always fatal. And now, in developed countries, the 5-year survival rate is, what, 96%? That's just incredible progress.
It truly is, and that progress comes from a very clear set of priorities in treatment. The number one goal, always, is to save the child's life. That comes first. Then the secondary goal is to try and save the eye itself, if possible. And the tertiary goal is to preserve as much vision as possible. It's never a one-size-fits-all approach. It requires a whole team working together. You've got ocular oncologists who specialize in eye cancers, pediatric oncologists, radiation specialists, geneticists, all collaborating.
Okay, let's dive into those treatment options then, because they're really the heart of this success story. You mentioned different types, focal, local, systemic. Where did chemotherapy first make a big difference here?
Well, the arrival of intravenous chemotherapy, or 5E chemo, back in 1994, that was a real turning point, a paradigm shift, really. Before that, removing the eye enucleation was much more common, especially for more advanced cases. 4V chemo meant we can deliver cancer-fighting drugs throughout the whole body. This dramatically improved survival rates, yes, but critically, it also meant many more children could keep their eyes. It shifted the focus from just surgery to a combination approach. Now, it's very effective, but like most systemic chemo, it does have side effects, risk of infection because it affects the immune system, potential hearing loss from certain drugs, and a very small but real risk of secondary leukemia down the road from other drugs used.
Right, so IV chemo circulates everywhere, but then came something called intra-arterial chemotherapy, IAC. That sounds incredibly precision, targeting the eye directly.
Exactly. Instead of bathing the whole body in chemo, the idea with IAC is to deliver a really concentrated dose right where it's needed directly to the eye tumor. It was pioneered in Japan back in the late 80s and started being used more widely in the US around 2006. What they do is thread a tiny catheter, usually starting in the groin, all the way up through the arteries until it reaches the ophthalmic artery, which is the main blood vessel supplying the eye. Then they infuse a high dose of chemo, often a drug called melphalan, directly to the tumor. The results can be amazing. It can achieve up to 100% tumor control in some advanced cases, affecting only one eye, potentially saving eyes that would otherwise have been lost.
That level of precision sounds fantastic, but I imagine it's not without its own set of challenges or questions, especially when you compare it to the IV approach that's been around longer.
That's right, there are definitely nuances. While IAC generally has fewer systemic side effects because less drug goes elsewhere in the body, it hasn't been studied in the same way as IV chemo, specifically in large prospective randomized trials. We have lots of data, but it's different kinds of data. Also, the main drug used, melphalan, is quite potent, quite toxic locally. And there's the procedure itself. Guiding that tiny catheter requires fluoroscopy, which is like a real-time X-ray. That means some radiation exposure, which doctors always weigh carefully, especially in children. So you have this very powerful tool, but maybe less long-term, large-scale comparative data than the older method. The choice between them often depends on the specific tumor, the child, and also the experience and preference of the medical center.
Okay, that makes sense. And then there's another way to get chemo right into the eye, intravitreal chemotherapy, injecting it directly into the eyeball. This sounds particularly important for something called vitreous seeding. What exactly is that?
All right, so vitreous seeding is when tiny bits of the tumor break off and float around inside the vitreous humor. That's the clear, jelly-like substance that fills the main part of the eye. Historically, this was really hard to treat. Often, it meant the eye had to be removed because systemic chemo, whether IV or even IAC, just doesn't penetrate well into that vitreous jelly. There aren't many blood vessels there. So intravitreal chemotherapy, where they inject a tiny amount of chemo directly into the vitreous cavity, gets the drug right to where those seeds are. And it's been a game changer for this specific problem, achieving maybe 80–90% success in controlling those seeds.
Injecting directly into an eye with cancer. I mean, intuitively, that sounds a bit risky. Was there a concern historically about maybe causing the cancer to spread outside the eye by doing that?
Yes, absolutely. That was a major concern for many years, and it prevented the technique from being widely adopted initially. The fear was that the needle track could allow tumor cells to escape. However, experts developed very specific, careful techniques to minimize this risk. For example, a standard safety step now is to apply cryotherapy freezing to the injection site 3 times as the needle is withdrawn. This essentially kills any cells that might be trying to escape along the needle path. With these safety protocols, it's proven to be effective without causing that dreaded extraocular spread. It's generally used as a salvage therapy, meaning for seeds that persist or come back after other treatments rather than a first-line approach. And it definitely needs to be done by specialists with a lot of experience in this technique.
Okay, so we've covered various chemotherapies. What about radiation? Is that still part of the treatment picture for retinoblastoma?
It is, yes. Radiation therapy can still be a valuable tool. Retinoblastoma is known to be quite radiosensitive, meaning the cancer cells respond well to radiation. Doctors tend to be cautious with radiation in young children because of potential long-term side effects on growing tissues. But when it is used, it's done in highly targeted ways. One method is plaque radiation therapy or brachytherapy. Tiny radioactive seeds are sewn onto the outside surface of the eye, right over the tumor, usually for about a week. This delivers a high dose directly to the tumor while limiting exposure elsewhere. Another advanced technique is proton beam therapy. This uses protons instead of traditional X-rays, and it allows for incredibly precise targeting, stopping the radiation dose right at the tumor, minimizing damage to surrounding healthy tissue, like the brain or the bone structures around the eye.
So a whole range of really specialized high-tech options.
Absolutely. And for smaller tumors, there are also focal treatments, things like laser photocoagulation, which essentially uses a laser to burn the tumor away, or cryotherapy, which freezes it, or even transpupillary thermotherapy, which uses heat delivered through the pupil. But despite all these incredible advances in saving eyes, it's important to remember that enucleation surgical removal of the eye is still sometimes the necessary and safest choice. This is usually for very advanced tumors in one eye where there's little hope of saving vision or controlling the cancer otherwise, or if other treatments have failed. After enucleation, children are fitted with an artificial eye, an ocular prosthesis, which nowadays can look remarkably natural.
It's so clear that managing retinoblastoma is this constant, delicate balancing act, weighing the risks and benefits of each option, always with the priority being life first, then saving the eye, then preserving vision. Okay, so let's say a child goes through treatment and it's successful, the cancer is gone. But the journey doesn't necessarily end there, does it? There's this whole aspect of late effects, potential health issues that might pop up months or even years later.
That's a really crucial aspect of survivorship care, yes. We need to think about potential long-term consequences of the treatments themselves. Now, the good news is that the risk of serious late effects from the modern chemotherapy regimens is generally considered quite low, but they can happen. For example, some drugs like carboplatin can potentially affect kidney function or hearing. Another drug, etoposide, carries a very small risk rare, but serious of causing a secondary leukemia, usually within about 5 years of treatment. And vincristine can sometimes cause nerve issues, though often temporary. Radiotherapy, while very effective at treating the cancer, can unfortunately have more significant long-term effects. Things like chronic dry eye, or sometimes facial asymmetry if the radiation affects bone growth around the eye socket in a very young child. Rarely, issues like retinal detachment can occur years later, and there's always a small but lifelong increased risk of developing a second, different cancer within the area that received radiation.
Right. So that means ongoing, personalized follow-up care isn't just a good idea, it's absolutely essential for optimizing their long-term health, isn't it? Especially starting so young.
Exactly, it's critical. The type of follow-up depends a bit on the situation. For kids who had the non-hereditary form, affecting only one eye, and who didn't need radiation, their specialized follow-up usually continues through childhood. Then they might transition to just regular care with their family doctor or GP. But for children with the hereditary form, or for anyone who received radiation therapy, the recommendation is generally for lifelong follow-up, eventually transitioning to a specialized adult late effects clinic. This ensures ongoing monitoring for any of those potential late effects we talked about and allows for early intervention if anything does arise.
And beyond the purely medical follow-up, facing something like retinoblastoma must be incredibly isolating and scary for families. What kind of support systems are out there for them?
Oh, the support networks are incredibly important, and thankfully, they are quite strong for retinoblastoma families. There are things like private, well-moderated social media groups specifically for parents, for adult survivors, for other family members. These allow people to connect with others who truly understand what they're going through, share experiences, ask questions, offer practical tips. And then there are fantastic organizations like WEC Hope, which is global, or the Childhood Eye Cancer Trust in the UK, and similar groups in other countries. These organizations provide amazing resources, reliable information, emotional support, practical help, sometimes financial assistance. They really build this global community of shared experience and, importantly, hope. It makes a huge difference knowing you're not alone on this journey.
That's so vital. So maybe a practical piece of advice for you listening. If you, or perhaps someone you know, had retinoblastoma as a child and you're not currently connected with a late effects clinic or follow-up program, it's definitely worth talking to your GP or family doctor about getting a referral. And reaching out to those support organizations we mentioned is another great step. They can often help guide you.
Wow. We have certainly covered a lot today in this deep dive on retinoblastoma. We've gone from recognizing those very first signs, like that unexpected glow in a photo,
Yeah.
through the really complex genetics involved, understanding hereditary versus sporadic forms, and into this incredible landscape of highly targeted, often eye-saving, and definitely life-saving treatments. It's truly striking when you step back and look at the progress, isn't it? How far we've come with this specific cancer. From a situation where survival was rare to today where, thanks to that focus on early detection, thanks to cutting-edge therapies like IAC and intravitreal chemo, and that commitment to lifelong follow-up and support, the outlook is just vastly different.
So thinking about that bigger picture, given these huge leaps in how we can detect retinoblastoma early, understand its genetic roots so precisely, and then target it with specific therapies, what could this journey teach us about tackling other complex cancers, especially other childhood cancers? How might the lessons learned here about personalized medicine, about proactive genetic screening, maybe even beyond eye cancers, shape the future? Could it lead to more targeted, less invasive, and ultimately even more successful treatments across the board?
It's a great question. I think this deep dive really underscores how powerful that combination of interdisciplinary teamwork, relentless scientific research, and a deep, unwavering commitment to the patient can be. It really can transform not just medical understanding, but fundamentally change and improve people's lives.